on the board site. There it is. The recording will be posted on the board's website after the meeting today. TVW may also be streaming this meeting to allow for additional public viewing opportunities. At this time, Sue Birch, Chair of the Healthcare Cost Transparency Board, will call the meeting to order.
So thank you, Kaylee. This is Sue Birch. I'm calling this meeting to order. Welcome, board members. We have three in the room with that are joining me. We have Jane Beyer, we have Eileen Cody, and we have Ingrid Ulrich. It's 2:02, and I am calling the November 7th meeting of this Healthcare Cost Transparency Board to order. Welcome for everybody joining us online and members of the public that are here with us in person. We've got a really full agenda, but I remind you that we've got an extra hour, but I'm still going to hustle us through as we have lots of territory to cover. So I will be kind of pushy, and I'm going to really ask people to be succinct with their comments, build off each other's comments. And I promise you we will take a break. This meeting, we're going to focus on continuing our discussion on a few of the board's selected policy priorities for this year, which came of the February retreat. As we have discussed, rising healthcare costs are one of the biggest reasons people delay or forego healthcare, making healthcare costs an underlying barrier to access for many. And as we can all agree, there's not one quick fix or not one simple solution, which is why our conversations continue to build one meeting after another. And it's why we continue to get feedback and have our advisory committees keep working for us. We've got to keep identifying the strategies for making healthcare more affordable and healthcare costs more transparent for all Washingtonians. Looking at today's agenda, first we're going to hear from Gary Cohen and Dr. Janine Smith from our Health Management Associate Partners. They're going to provide us with an overview of the best practices report, which, as all of you know, is a new board mandate that came out of this past legislative session with the passing of House Bill 1508, which requires us to study regulatory approaches and best practices from other states for the cost growth benchmark program. This is going to give us a good understanding of what other states are doing, what's working, what state agency is responsible for these programs, and what their structures and oversight authority looks like. It's going to help us tee up the conversation for us to have about our thoughts and potential areas of improvement here in Washington. And Eileen's dog is indeed barking. So it's not me. Really some humor in that. Okay. We're also going to hear from Gary and Janine from HMA again as they give us a brief introduction on business oversight, mergers and acquisitions. Then we're going to hear from Maureen Hensley Quinn at Nashby and Hayden Brooke Lay from Brown University School of Public Health about the model legislation to address consolidation closures in healthcare. We're then going to have a discussion focusing on the takeaways from those last two presentations and hone in on our recommendations for the market oversight and transparency. This will require a vote, so I will be reminding you that we'll have to take some action. At 3:45, we're going to take a quick break. And after we hear from Joe at IHME on the ASI report, which has been updated since the last time he presented to us to include data from 2019-2022. Following that report, we'll do a brief recap on the board's work on facility fees. And then finally, we are going to discuss the draft 2024 legislative report. We will vote on adopting the report with some additional inclusions, language updates, and public comments based on today's meeting. So we got a lot to cover. I saw several of you, or talked about several of you this morning at a very important meeting we had up at UW. IHME convened a group on the state of U.S. health and the state of health in Washington. And spoiler alert, we're spending a lot of money and we're seeing reduced longevity and reduced outcomes in certain areas. We can be doing better. It did not talk about cost. It talked about kind of all sorts of other things. I will send you the slide deck, but it continues to be startling how we in Washington, we're outperforming other states, but we are underperforming from other nations, and we are simply spending too much. So there will be more coming as all of that work continues to play out. And our UW partners did announce that there will be articles in JAMA and Health Affairs in February or March and April about how Washington continues to have some good success with our strategies. So more to come as they release more of that information. So with that, let's do a quick roll call. If you'll open up to tab 1, Jane Fire, are you present?
Yes, I am present.
Eileen Cody,
Here.
are you here?
I'm here.
Lois Cook, are you with us?
Present.
Thank you. Bianca Frogner.
Here.
Jody Joyce. Jody's not on yet. Staff, let me know when she joins us. Greg Marchand, are you on today? I think that was a here.
No.
Is that a here?
No.
Well, staff will let me know. Mark Siegel, are you here from Costco? Not yet. Margaret Stanley, I think we were expecting Margaret was not able to join today. All right, Ingrid Ulrich, here. Thank you. Kim Wallace.
Yes, here.
Great. Carol Wilms.
Here.
Thank you. And Edwin, I don't think Edwin Wong could join us today. All right, we'll turn now to our next agenda item, the approval of the September meeting summary. Tab 2, everybody, if you'll jog along with me. Are there any, they're being shared up on the screen, but is there, let's see. I do want to remind everybody that the recording of the last meeting has been posted on our webpage for reference or review. And we're going to do a consensus process for the vote on the approval of the meeting summary. Any discussion, any comments, any changes that need to be made? Oh, thank you. Kim, I think you might have been first, and then Bianca.
I just wanted to make a note there in the public comment, the first speaker from Multicare. There is in the first paragraph, there is the use of the word Medicare, and I'm pretty sure it should be Multicare.
Thank you for that, Bianca.
Oh,
Oh, I'm sorry.
Kim. That was Kim.
Sorry, and I was multitasking. I am getting a text from Greg that we need to add him as a presenter, please. And we'll note that Greg Marchand is joining.
I just wanted to clarify, I see that the data issues minutes are also in here. Were they intended to be in here? It's before the board's minutes in here, so just wanted to clarify.
They're in the packet. I will clarify with staff. I don't believe we have any recordings up, but thank you for that. Other comments? All right, is there a motion to approve the minutes with those corrections?
So moved.
Thank you, Eileen. Is there a second? Second. Thanks, Ingrid. All in favor, say aye.
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 Thank you. Any opposed? All right, this motion is approved, and we're going to move on to tab 3. As before, we put up our public comments early in this process because our stakeholders have asked us to do that. And I remind everybody that written public comments received since our last meeting can be found under your 3rd tab. And we allow individuals to sign up to provide public comment for the meeting. And we will start with those that have signed up to provide comments. If you've not signed up and would like to provide public comments, please raise your hand. And Kaylee will call on you after we hear from individuals who have signed up. When you are called upon, please state your name and affiliation, if any, before speaking. And please accept the invitation to become a panelist in order to turn on your camera and provide public comments. Given the number of public comments that we've been getting at our board meetings, we are introducing a 2-minute limit on public comments at the board meeting. So I either ask you to speak quickly or just be mindful that we will be putting in to limit the time frame so that we can keep moving the board along. You're always welcome to provide comments in writing via email at any time. Kaylee, would you please start with the names of individuals, if any, who have signed up to provide comments? Oh, Jeb is here in the room, so we are going to begin with Jeb.
Members of the board, my name is Jeb Shepard, representing the Washington State Medical Association. We appreciate the opportunity to provide feedback on your work centered around our shared goal of reducing healthcare costs. I want to congratulate the board and the Healthcare Authority staff for achieving 2 recent milestones, distribution of benchmark reports, and putting together this year's report to the legislature. That's where I'll be focusing my brief remarks today. In regard to the benchmarking reports, our physician group, subject to public reporting, were eager to receive and review their reports. I was able to connect with each to discuss and understand how the reports might be improved so they're more actionable and can assist practices in meaningfully and responsibly reducing costs. I'll submit more comprehensive comments for consideration before your next meeting, but here are 4 examples where we offer constructive feedback. The Medicare data is incomplete. As an example, the data does not include Humana, which is a large Medicare Advantage partner. For one of our groups, I learned that the Medicare data in the report only reflects about 30 to 35% of its total Medicare population. Number 2, in order to drive meaningful change, there should be a process whereby physician groups can verify accuracy. Our members are concerned about aggregation of data at the provider entity level because it poses significant challenges to validate, does not allow for understanding costs and potential outliers. To address this issue, we recommend sharing data provided by carriers at the TIN level in future reports. The current directions given to groups for verifying data is very burdensome at the moment. There's room for improvement because they are told essentially to reach out to carriers to understand the data without a list of contacts. And so we'd urge a more robust and collaborative process that includes providers. And finally, context is critical. As cost does not always mirror utilization. Under this paradigm, if a patient is attributed to a physician group and that patient is hospitalized, the costs are attributed to the physician's practice. Physician practices have no control over those contracted hospital rates. We would ask that this data is publicly reported. That context is provided. We also believe that utilization data should always be included with cost data.
Thank you for those public comments. Kaylee, can you tell me who else is signed up?
Yes, next up is Katerina LaMarche.
Great. Go ahead, Katerina, you've got 2 minutes. If you'll identify yourself and your affiliation.
Hi, thank you. Katerina LaMarche with the Washington State Hospital Association. Just want to say we've had limited time to review the legislative report, but on first pass, we note a couple issues with the findings and underlying assumptions. So we'll be sharing those via formal comment. I would instead like to focus on today's discussion and vote on facility fee recommendations. I know we provided many comments at the last few meetings, but we would like to reiterate sort of the overarching issues for you to consider when you have that discussion. Facility fees help sustain hospitals. They help pay for staff, supplies, other necessary costs, which are in pretty financial distress in the state. Government programs underpay hospitals. For the cost of outpatient care for their enrollees, and eliminating facility fees will affect safety net providers and access to services for Medicare and Medicaid covered patients. And so we just ask that any vote that you consider, any recommendations that you consider today, especially on the reduction or elimination of facility fees, really needs to be deeply vetted to really fully determine the impact to patients' access to care, especially in rural areas. Thank you.
Thank you, Katerina. All right, Kaylee, who's next?
Next up is Zosha Stanley.
Great, Zosha, you want to go ahead and identify yourself? And you have 2 minutes.
Great, thank you. 2 minutes like the legislature. I appreciate the timer. I'm Zosha Stanley. I'm the Vice President, Associate General Counsel at the Washington State Hospital Association. Wanted to just give a couple comments today on the business oversight discussion that the board will be having and then voting on, I think, later in the meeting. Wanted to start by noting, as we have with other topics, that we think that Washington data and information is really important to consider when you think about solutions in Washington. And wanted to flag that the NASHB model legislation, at least based on the slides we've seen, kind of presupposes there's a void in underlying law in Washington state, which is not the case. Washington does require hospitals, health systems, and provider organizations of 7 or more providers to submit pre-transaction notice to the Attorney General's office prior to the transaction being completed 60 days before. Washington's review of transactions includes both in-state entities and out-of-state entities with sufficient patient revenue in Washington state. Worth noting that Washington's law does not include right now, and you might consider expanding, or the legislature might, to other entities. For instance, in other states, we've seen private equity and insurers become more active in the healthcare marketplace, and those entities are not subject to the pre-transaction notice in Washington state. Also of note, And I think you'll see this in the slides. Washington State does have a corporate practice of medicine doctrine. It's in case law versus statute. And also in Washington hospitals do report ownership and control of healthcare entities via consolidated annual reporting. And the nationally modeled legislation, at least the slides we've seen, don't include or reflect those existing Washington laws. And I wanted to also note with respect to conversation about oversight by healthcare state entities, there's going to be some talk about what other states have done and what other state cost boards do. I wanted to note that in other states, there's a unique structure for the capacity of other agencies when it comes to marketplace oversight. So just wanted to flag that if in Washington State we have new entities or agencies oversight of transactions, those agencies need to make sure that they have the requisite expertise to perform that oversight. Thank you.
Thank you, Zosha. All right, Kaylee, do we have any other speakers?
I am not seeing any additional hands at this time.
All right, last call here in the room. I don't see any. I'm finished. No, you don't get more time. All right, thank you all for these public comments. And again, we welcome anyone who wants to submit additional comments to do so to the cost board's email address any time of the month. And we integrate those into our board handouts and get that information out. Next, we're going to get Gary Cohen and Dr. Janine Smith from HMA. They're going to walk us through the findings of the best practices report, which focuses on 8 other states that have cost growth benchmark programs. And we're going to have a brief discussion at the end of that. So welcome, Gary and Janine. And their slides are up and they are under tab 4 as well.
Hello, I'm Janine Smith from Health Management Associates, and Gary Cohen and I will be tag teaming this section. We were asked, and go on to the next slide, I think. We were, the legislature directed the cost board to study best practices from other states regarding the infrastructure of their state health cost board programs. We were asked as health management to conduct this analysis. We did an environmental scan that was conducted across the states for those that had active cost growth programs. Looked at approximately 8 states, and 4 were identified for a more detailed survey and interviews to further understand their program structure, their scope, financing, and staffing. We also wanted for those states, that also had business oversight programs to better understand how those were structured as well, to oversee mergers, acquisitions, etc. And then we compared that with some of Washington State's efforts to date, and that is in your best practices report attached to the legislative report. Next slide. So 8 states have active cost growth benchmarking programs at this point in time. The first in the country was Massachusetts in 2012. Delaware and Rhode Island and Oregon came in 2018 and 19, and then Connecticut along with Washington State in 2020. New Jersey's was in 2021, and then California, very new was 2022. They have variable results to date. The COVID pandemic, as you would expect, has had some impacts both in getting the program started as well as the changes in utilization related to the pandemic. There was a 9th state, Nevada, that was initiated by executive order, but was not supported on a change of a governorship in that state and is not currently active after 2023. All of these 8 programs that are active, they all have some amount of authority to collect and use data to monitor their health system spending trends. They have a growth target that against which they measure those spending trends. Their spending measurement to collect and track healthcare expenditure. There's each have their differing ways on how they measure that. They do all have some data and analytic capacity to support data analysis, reporting, and use cases. The data use strategy is also being considered in terms of how to advance state strategies to address affordability in their states. There is public reporting with steering committees, much like this board in all the states. And then there are a handful of these states that also have market oversight programs. Next slide. This just is it's a more detailed slide, but just talks about the 4 states that we really honed in on: California, Massachusetts, Oregon, and Rhode Island. It lists out which agency is responsible for the program and its structure. And what we've have included in your report is identifying, was this a new office that was created? How was it created? Etc. I'll go through each of these 4 states in a little more detail on the subsequent slides. So Massachusetts, the oldest one, and one in which many of the other states have looked to for examples on how to conduct their own programs. They created a health policy commission agency that is an independent state agency. It has 3 key functions: focusing on care delivery transformation, the healthcare cost containment, and then the market oversight and monitoring. They work very closely with their Center for Health Information and Analysis. This is their all-payer database and hospital financial data collection entity. On the left-hand side are some further details about the Health Policy Commission. It is very well funded in order to achieve all of these 3 areas. hca itself has a separate budget as well. There is a staffing focused in each of the key areas, and there's some detail in there in terms of types of staff they have hired and some of the consultants that they have used to support their work. And the funding, which is unique about Massachusetts, it is via an annual assessment of hospitals and that have associated with delivery systems, payers, and ambulatory surgical centers. Next slide. Oregon, where I am sitting actually at this moment, has 2 programs: a cost growth target program and a market oversight program. Both of these programs were set up inside the Oregon Health Authority, which is our large agency here, has Medicaid, public health, behavioral health, and our state employees programs inside it as well. It sits inside where we pulled all of our policy and analytics together into an Office of Health Policy and Analytics back about 10, 12 years ago. And we were already collecting hospital financial data there, and we had built an all-payer database. And then these 2 programs sit inside that program. There's a lot of cross work between the analysis staff amidst these programs and that of the Office of Health Policy and Analytics. A much smaller budget, about a couple million for their cost growth target program. They have a smaller staff subsequently, although, as I said, closely integrated. And they are able to engage some outside consulting. There has been a lot of funding to all of these states from the Peterson Foundation, a national foundation that has been promoting how to help states address affordability. They are seeking some new funding to try to expand some of their policy staff to augment their policy analysis and to add some further legal expertise in for their market program. Next slide. Rhode Island, equally unique in that it was set up by an executive order, was placed in the authority was placed under the Office of the Health Insurance Commissioner. This is unique to nationally in the sense of having a health a commissioner that's focused exclusively on health insurance. And it works closely with the Health and Human Services agency where the all-payer database is in order to be able to do their work. Again, the smaller funding, no real dedicated staff. They do a lot of use of consultants as well as use of the staff over in the Office of Health and Human Services. And they have quite a bit of extensive work engaging with the stakeholders in the state of Rhode Island. It is a voluntary, there is a more voluntary components to their program with a strong voluntary compact that actually led to the development of this program. Next slide. And then California, a Office of Healthcare Affordability was created inside their office of their Department of Healthcare Access and Information, which lives inside their much greater, larger entity of Health and Human Service Agency. They also are focused on not only cost growth, but also market oversight, as well as promoting high value in primary care, behavioral health, workforce, all value-based payment. Their funding is probably the most extensive, $22 million. They have authority for 80 positions, but they've sort of been, since it's relatively new, starting to transition from consultants to hiring staff and then making that transition over to bring more staff in and less investment in outside consultants. And they have set their targets, but have not yet released information. It's just starting up. Next slide. So this I will turn over to Gary to kind of give us some basic overview of highlights of these, what we found overall.
Thanks, Janine, and it's great to be with you all this afternoon. The report is organized by different elements of the functioning of these programs, and so I'll be walking through those. So starting with governance, here we really were not able to identify one, or more best practices because it really does depend on the political environment that led to the creation of these programs. The states have differed in terms of where they placed the program and how they were staffed. So the key distinctions to bear in mind, I think, is the relationship between the entity that's responsible for establishing cost growth targets and monitoring, and then the state agencies within the executive branch that in one way or another are involved with overseeing the healthcare system. So solutions have ranged from having the cost benchmark program within an existing state agency as a program, such as what Oregon has done, to, at the other extreme, having an independent board with full authority over the program and its own staff, as in Massachusetts. And California arrived at something of a hybrid. So the Office of Healthcare Affordability is an executive office sitting within the Health and Human Services Agency, but it has a board that is given specific authority over certain aspects of the program in the legislation. So, for example, it's the board that sets the cost growth targets, not the staff of the state agency. And it's the board that generally sets, sort of strategic parameters for the program, which is then implemented by staff within a state agency in the executive branch. And as Janine noted, Rhode Island is a very different model in that there really is no cost board. It's the insurance commissioner working with a voluntary compact of stakeholders who came together to address affordability and reached an agreement to have a program that would perform some of the same functions as these other programs. In terms of data collection, the issues really are two. One is how comprehensive is the data that's collected? Are there gaps? I think we heard a little bit from some of the public comment about some gaps that may exist in Washington, or data that's not as complete as it might be. And then the second issue is how centralized or decentralized the collection, analysis, and reporting of data is, with, again, Massachusetts being the kind of platinum model in the sense that they have a completely independent agency dedicated solely to collection, analysis, and reporting of data with respect to the healthcare system, and very broad and comprehensive authority to collect that data. And if you look at the hca website, if you have a few spare minutes, you will be very impressed by the range and the scope of reporting that they do on many, many different aspects of the functioning of the healthcare system. The next issue is what authority the agency has to enforce compliance with cost growth targets. Basically, of the ones that we looked at, Massachusetts, California, and Oregon have some kind of progressive enforcement authority, beginning with imposing performance improvement plans on entities that have failed to meet the cost growth targets, going all the way to, under certain circumstances, over time, the possibility to administer civil penalties. No cost board has administered civil penalties to date, and there has only ever been one performance improvement plan that Massachusetts issued to Mass General Brigham Health System that directed it to achieve $176.3 million in savings through a variety of different very prescriptive steps that they were required to take. And as of today, they have been reporting out on the progress of meeting those obligations and have been on track to achieve the savings that they were directed to make in that performance improvement plan. The next topic is market oversight authority. So here, as you know, consolidation within the healthcare system, both horizontal consolidation, meaning health systems merging and acquiring each other, to vertical integration, where, for example, insurance companies are purchasing medical practices, Optum being the sort of the prime mover in this area, have led to concern over their impact on cost, access, quality. And so the key question here is, number one, as one of the public commentators mentioned, most states, including Washington, have some sort of reporting requirement for transactions. They have to be reported a certain period of time before they can close, and there's review that's possible. But the one key issue is, what's the standard of review? What is the reviewing entity allowed to look at? In many states, that's just traditional antitrust analysis. What's the competitive impact? Is there, going to be a monopoly created through the merger of these entities? Whereas in other states, and here Oregon is really the best example, the transactions can be reviewed under a sort of a public interest standard. So the question is, what's the impact on cost of healthcare, access to healthcare, quality, equity, all the various factors that might be influenced by a particular transaction. And then in Oregon, their market oversight program, which again sits within their healthcare authority, has the authority to approve transactions, disapprove with conditions, or disapprove entirely, which is unlike the authority really in any other state at this point. Most states permit a referral of proposed transactions to the Attorney General's office for review. So that's another question. Sort of, where does the reviewing authority exist? California has broad ability to their Office of Healthcare Affordability has broad ability to review and report out on impacts of transactions, but no authority to actually decline to approve a transaction. Next slide, please. So then we also looked at some other state policies that directly impact healthcare prices that may not necessarily be within the cost benchmark program, but still obviously affect affordability of healthcare. And so we thought it would be useful to talk about those as well. And here again, Oregon has the broadest authority in this area. It passed a law requiring health insurers and third-party administrators contracting with their state employee plan to cap payments for hospital facility services at 200% of Medicare rates for in-network and 185% of Medicare rates for out-of-network. And they showed some significant impacts and results from that program. Rhode Island, as we've indicated, and really the reason why we looked at Rhode Island for purposes of this report is it has the insurance commissioner has used its rate review authority to limit increases in hospital prices, and it has a formula that's based on what happens to Medicare price index and inflation, and caps in hospital price growth year over year using that formula. And it recently reported some results from a reduction in spending as a result of that program. And as I think you know, there's now proposed legislation in Washington that would do something similar to what Oregon has done, using a price reference to Medicare rates for the public employee and school employee plans. And then the last thing that we looked at was funding. And here, we didn't think it would be very helpful to the legislature to just say, gee, Massachusetts and California get a whole lot of money. So we thought it would be, most instructive to point out that once you've decided what you want these programs to do, and they do vary in terms of the scope of what they look like, what they look at. Some have broader scope and some have narrower scope. So some of the programs are concerned with extended primary care spending, for example. Some of the programs are in California, they have a standard for adoption of alternative payment models. So some of them have broader scope than just setting cost benchmarks and monitoring compliance with those. So once you decide what you want the program to do, then obviously, it's important to have funding that is reasonably scaled to the mission of the organization. And then the other thing that we found, and Janine mentioned, which is significant, is that in some cases there is a dedicated funding source outside of the state general fund that provides some of the funding for these agencies. So they're a little bit freer from the state budget cycle and being subject to reductions in funding, in years where there's a tight budget situation. So that pretty much summarizes what we did. Next slide, please. There's a lot more detail in some of the slides following this presentation in your packet, and then there's of course a lot more detail in the report itself, which you have in draft form. We welcome your comments and suggestions for the report. There's still time for changes to be made in the report before it needs to be submitted to the legislature in December. And we welcome today any questions and comments that you have, particularly whether you're interested in further discussion of any of the best practices that we've talked about briefly here, that you'd like to look into more in terms of consideration by the legislature.
Great. I really appreciate these reflections and just the way you've encapsulated everything from the other states and the opportunities that it presents for Washington. I remind you guys that we have grown to 5 staff 3 dedicated for data, 2 for policy, and we have about a little less than 600,000 a year in our resources for contracting and whatnot. So we have been doing this on a shoestring. And I do want to just point that out when you look at the magnitude of the staff in other states that are really dedicated to this, or how they've absorbed it through their insurance. I think it's really important, and a huge shout out to our staff. They have continued to push this forward. And it's only fair to say that Washington has sprinkled resources in other places. I don't know, Jane, how many people you would say you have dedicated to some of this work, but I wouldn't say dedicated as a fair word for any of the state agencies. And I remind everybody too, the Washington Health Alliance has about 4 or 5 staff members, and that is all, and they are not focused singularly on this issue, but I know they are aligned thought partners in this work, but we have a lot less resources in Washington. I'm wondering, Gary, Liz, and Janine, do you want to reorient us now to the policy topics that we focused on this year, and then lead us into our first policy topic today, the market oversight piece? And if so, that's under tab 5. All right. So let's.
Everybody, it's good to see you. Can you hear me?
Yeah.
Just making sure. Okay. Just wanted to take a quick second to just, as Chair Birch mentioned, reorient everyone to where we are and what we're doing with the cost board. There have been some questions about the different focus areas that are coming up and being discussed, and just wanted to take a moment to pause and respond to that. As Chair Birch reminded us earlier, the cost board was created in response to the growing impact of healthcare affordability on consumers, employers, and the state budget. And at the same time, recognizing that consumers are continuing to face these growing out-of-pocket expenses. So earlier this year, as the board came together at their retreat, and started shifting more towards looking at policy interventions and actions that they might be able to take to address the healthcare costs, it became pretty clear that many of those policies are going to require have a little bit of a longer term timeline to develop those. And in the meantime, there seemed to be a recognition from the cost board that we want to think about. They want to think about a little about some of the policies that might be available in the shorter term or medium term to really target medical debt and the affordability challenges that folks are facing. So we can go to the next slide. I'm not going to go into the details on this slide, but this is really just to help sort of organize how these different pieces are. We're looking at them and organizing them. And there's just the 3 buckets. Again, the longer term strategies, which are more focused on costs and using the data that's been collected by the cost board over the last couple of years and ongoing. And then the second bucket is the medium term strategies focused on affordability. And then finally, the strategies on consumer medical debt, which are the shorter term strategies. And over the course of the year, we've kind of bumped in and out of many of these 3 buckets, and we'll continue to do so. But and we're going to turn to the next slide. And today, we're going to be focusing on 2 of those areas, healthcare costs, specifically on the business oversight of mergers and acquisitions, and the second bucket of consumer affordability, and circling back to the conversation about transparency and facility fees. So with that, I'm going to turn it over to Gary.
Thank you, Liz. We can go to the next slide. So why are we talking about this subject in the context of affordability? The reason is because numerous studies have shown that consolidation, including both, as I mentioned, horizontal consolidation among entities of a similar type, combining, and vertical integration with, for example, health insurers taking on acquiring more aspects of what happens in healthcare, whether it be pharmacy benefit managers, whether it be pharmacies themselves, CVS Aetna being, an example of that type of integration. Limit options for purchasers and lead to higher healthcare prices, increased healthcare costs, and increased medical debt. Really interesting study that just came out from the Urban Institute in the last few weeks, directly tying the incidence of medical debt to the degree of consolidation in the healthcare market. and finding that where there's more consolidation, it leads to more medical debt. Private equity ownership, and this is an emerging area of concern, I would say, and in some states have done more to gather data on what private equity transactions actually are happening in the state and what their impacts are, but they have also been associated with increased cost and with mixed or harmful impacts on quality. So that's why we're here. That's why this is a topic for this board to be examining. Next slide, please. So in the a report that the Insurance Commissioner's Office put out last year, the preliminary affordability report, there was a big section of that report covering what's happened in Washington State with respect to healthcare consolidation and private equity investment. And you can see some of the statistics here. The conclusion being that the system is highly consolidated and more consolidation is happening all the time. So this is something that is happening in Washington and has given rise to concern among policymakers as to what, if anything, should be done about it. Next slide, please. So as we've talked about during the best practices report, several states have adopted policies that permit review. Some states have given broader scope of review and authority to approve or disapprove transactions. This board has talked about this issue several times during this year and has noted that the state does not have complete information on ownership of healthcare entities and private equity investment, which is not reported. This year, there was a proposed piece of legislation, the Keep Our Care Act, which would have required additional entities to file proposed material change transactions for the Attorney General to review. That legislation did not pass. So we've asked for a presentation today from the National Academy of State Health Policy, NASHB, which has worked to develop model legislation for states to consider, focused in part on providing more oversight on mergers and acquisitions. So we have Maureen Hensley-Quinn, who's the Senior Program Director at NASHB and leads the Coverage, Cost, and Value team, focusing on states' efforts to finance, provide, and improve coverage and care through public and publicly subsidized health programs. And we have Hayden Rook-Lay, who's a health law and policy fellow at Brown University School of Public Health and a senior fellow at the American Economic Liberties Project, whose writing focuses on issues of healthcare law and policy, including corporate consolidation of medical providers. So I will turn it over to them and thank them for their presentation.
Yeah, and board members, I just point out that all of this is available under tab 6, and welcome to Maureen and yes, welcome.
Thank you. Thank you so much for inviting us to this conversation. I will start with just a very brief overview of NASHB and why we're involved in this space, because I think it's important for the context. NASHB, as many of you know, I know many on the board already are familiar with NASHB, but we really strive to support states in identifying first policy problems and then identifying solutions. And that is paramount for our healthcare cost work. We do have a group of state officials that we've been convening that focus on discussions related to consolidation. And increasingly, those discussions have been focused on private equity, which private equity is not the only problem within consolidation. Gary laid it out really nicely that with increased consolidation, and health entities amass more power, and then they can which drives up price. Private equity then comes in because they see an opportunity to make money off some investments, and then that sort of changes the business dynamics of some of the decision making that has had an effect on access to services, cost, and states have started to take serious notice of this. So as we were working with states, we had different models out there that states had asked us to create, but we heard a lot about needing more and overall more comprehensive approach to this. And so that's what prompted NASHB to pull together this model. It really was developed in partnership and with guidance from a group of state officials. The state officials that participated included Oregon because of uh, their experience, their direct experience implementing a market oversight program. We asked them what they wish they had, and that is incorporated in this model. We asked them what has been working. Other states that have some level of authority within their attorney general's office also participated. There were states that had robust or have robust certificate of need programs that do some market oversight. They participated. And so this really is a reflection of what states want in a resource. Next slide, please. So it includes three major components. This was done on purpose, recognizing that states may not want to take this whole cloth, recognizing states may not need to take it whole cloth. And so there is one section that is devoted to healthcare transaction oversight. There is one section devoted to strengthening the prohibition on corporate practice of medicine, which includes banning physician non-competes, which was also an expressed ask of states that NASHB pulled together some model language for. And then there was also interest from states to better understand ownership currently. So we will walk through each of these different sections, but I did just want to underscore, we recognize that this is a large piece of legislation. We recognize that states have to consider this very carefully in deciding what their markets need, what their staffing capacity can handle. So I want to just underscore that wholly, that this is not intended to be something that a state has to do all in one piece of legislation, but the pieces are also designed to work together should a state want to take that approach. Next slide, please. So the first part, NASHB had a model policy that was already available beginning in like 2021 that really mirrored what Oregon and there were some aspects of what Massachusetts has been doing. However, like I said, those states were participants in our advisory group, and we incorporated what is working for them, but also some provisions, what they wish they had. And so we really did try to enhance this section. So next slide. Thank you. As has been noted, the policy concern here is that antitrust tools are not adequate to address the changes that are happening in the healthcare market right now, including private equity, but also increasingly, I know Washington understands this, but other states have been bringing to us the serial sort of transactions that are happening over multi-year periods that successfully subvert antitrust, but end up over time creating a very large consolidated systems. So we set out to strengthen a state's oversight authority. We hear from states that have no oversight authority, and it usually comes when they have heard that there is a transaction that may happen in their state. It can be a transaction between provider groups, it can be transactions between hospitals, it can be transactions between hospitals and provider groups, but increasingly there are also transactions that state officials reach out to us and say, what are my What can I do about a health plan that is outside of our state that wants to buy a large provider group or buy a large hospital? And without expressed authority, there really isn't a lot that a state can do to weigh in on that transaction or to help direct that transaction or even have notification of that transaction. So this authority expressly requires prior notice of material transactions. It allows the state to have a review authority. It does also allow a state to approve, deny, or approve with conditions a transaction prior to it happening. It's important to note that the way this was written, it allows that authority without a court's intervention. That was something that states expressly asked for, and that Oregon has been able to work within their law that provides them some level of flexibility and also allows them to leverage the expertise in their healthcare authority, given how much data expertise they have and given what they know about their own health market. They work hand in hand with the Attorney General's office, but the healthcare authority and their team that is devoted to market oversight really is focused on costs, on health equity, access and quality in a way that the Attorney General is not. And then it also expressly expands the role of state agencies to have oversight to collect information. And there is also a provision within the model law that asks proposed entities to contribute financially to the review. So there's a recognition that there is state cost involved in this, but those that are proposing their transactions have to contribute to the review. This helps provide some funding for the state staff, but it's also Oregon recognizes that they need consultants that help them with these reviews, and the entities proposing the transactions essentially pay for those consultants. Next slide, please. Importantly, this expands the scope of the entities covered under this law. So it does include expressly private equity investors, management service organizations, which is a contracting mechanism that private equity uses quite a bit to make their investments. It also includes real estate investment trusts. It specifically focuses on payers and staffing companies as well. As you can see, we included transactions such as sale leasebacks that's related to real estate investments, serial transactions, closures is another one, asking for notification of a closure before it happens, staffing agreements, and it also strengthens enforcement authority. So again, this is designed for either the AG to take wholly, but a recognition that that may be a lot for an Attorney General's office to take on, but to be able to work collaboratively with an office that has an understanding of the health market and the goals the state has for access to services, costs, and other things. And then importantly, Oregon has shared with us, as has Massachusetts, that ongoing monitoring of transactions after the transaction has happened is essential to understand the ramifications and the impact of those transactions. Next slide, please. And I believe that brings us to the second part. And Hayden, if you're on, I'm going to hand it to you to walk through corporate practice of medicine.
Wonderful. Thanks, Maureen. And thanks everybody for having us today. Wonderful to be speaking with you all. I hope I've been having some internet issues. So if there are any troubles, please someone jump in and let me know, just so I know I'm coming through okay. And if not, that we can fix it somehow. So I'm going to talk just briefly about the second element of this model law. I was told there's potentially less interest on the corporate practice of medicine side, so I'm going to keep my remarks brief. If there are more questions in the Q&A, happy to elaborate on anything here. Maureen, if you want to jump to the next slide, or whoever's controlling. Wonderful. What is the corporate practice of medicine, or the ban on the corporate practice of medicine? This is a concept that folks may or may not be familiar with, although it is a doctrine that arose out of state common law or judge-made law and is in existence in states across the country, including, I believe, in Washington. And generally, what the corporate practice of medicine or the ban on the corporate practice of medicine says is that, unlicensed lay entities cannot own or employ physicians, and in this case, unlicensed lay entities include corporations. And the sort of the main instantiation, the main way that this shows up in states is through their legislatures. And essentially, what the doctrine says is that for-profit medical practices must be majority or exclusively owned by licensed medical providers. So when we think about the rise of private equity or insurance conglomerates acquiring medical practices, it sort of forces a question. It's like, well, if states have these bans on corporations owning medical practices, how is it that private equity, for example, owns a medical practice? What does that mean when we say that private equity owns a medical practice? And this is where the answer to this helps us understand sort of how these laws have been eroded and what state attempts to strengthen them might look like. So the answer here to that question is that medical practices, when private equity or another corporate entity, quote unquote, purchases a medical practice, they're not actually acquiring the physician practice. The professional corporation or the limited liability company that has to be an management services organization or an MSO to essentially to de facto acquire control of the practice. And this is often referred to as the MSO PC structure or the friendly PC structure. And in effect, what you have here is the management services organization, through a combination of contracting practices with the PC, the professional corporation, essentially becomes the de facto owner of the medical practice. Next slide, please. And so the model legislation and what we've seen a couple states attempt to do in the last year or so is to really try to address this friendly PC structure, sort of the way to kind of update the corporate practice of medicine to the current day environment is to address this legal workaround that allows a corporation to essentially to de facto again become the controlling entity in the medical practice without legally owning the practice, because again, states require that these practices are owned by physicians. So what we described and what we propose in the model law are a host of different structures that would restore what we kind of refer to as this principal agent relationship of a professional corporation and management services organizations, trying to restore again this model where the professional corporation owned by the clinicians are the principal kind of actors, operating their medical practice. And insofar as they use management services organizations, which the model law and all the proposed state laws certainly permit, but insofar as they're using medical or management services organizations, it's as vendors to the medical practice, again, rather than having the management services organization essentially be the one controlling the medical practices, subordinating the physicians to it. So there's a whole number of specific provisions that we enumerate in the legislation. For example, banning a practice where a management services organization will take control of the equity of a clinician in their practice, which is known as a stock transfer restriction agreement. That sort of contracting arrangement would be banned in the model legislation, as would be, as Maureen said, non-competes and other restrictive covenants that, again, put the management services organization in a position of control over the professional corporation. Also, a number of of conduct or sort of practices that we see in these relationships that, again, might invert the relationship between the management services organization and the professional corporation. This might be practices around controlling diagnostic decisions, controlling how much time physicians spend with their patients, or other operational decisions. The legislation proposes that those decisions remain within the hands of the professional corporation, again, banning them from being delegated to the management services organization, because these are other ways in which that MSO, again, takes kind of de facto control of the medical practice. So that's the general gist. Again, I'm happy to elaborate in Q&A if there's more interest on the corporate practice of medicine side. But the idea here is to restore that relationship, that principal agent relationship, where the professional corporation and its owners, its physician owners, as is required by state law, remain actually in control of their practice and use MSOs to provide them services on a contracting basis, rather than the MSO actually taking control or de facto control of the medical practice. I will hand it back off to you, Maureen.
Great. And then the final part is focused on transparency of ownership. Next slide, please. This requirement comes from requests that were coming to us at NASHP from a number of different states and actually some employer groups as well, who were asking for, is there any language that can be used to require disclosure of ownership or changes of ownership of providers licensed in the state? The problem has been when there are closures, particularly folks were citing in rural areas, and then there was, it became clear after the closure, one, there wasn't notice of it, two, after the closure, that the small hospital or the doctor's group was actually owned by a larger health system. And there were just questions about what decisions were being made by the health system to close that entity. This again is it doesn't give the state authority over the decisions to close the health entity, but it does require reporting of ownership and change in that ownership to, we just assumed the Department of Health would make the most sense, the licensing entity. Next slide. This goes over it in a little bit more detail, but it also notes we were specifically asked by states to include nursing facilities, nursing long-term care facilities, insurers, PBMs, and so they are noted in here. The frequency would be annually or upon a material change. And then, as you can see, there's specific information that would be required to be reported. Next slide. So we wanted to also provide just a snapshot of what states are doing. I will just note, as was already shared, there's a spectrum of healthcare transaction oversight that states have. And we highlight Oregon, Massachusetts, and newly California as states that are sort of leading in being able to make determinations about the transaction. So giving approval or conditioning, and then again noting that for Massachusetts, in order to do that, they leverage the Attorney General's office, as does California. Oregon does this in a partnership with their Attorney General's office, but their program really does have authority to make those determinations. Corporate practice of medicine, we know that many states have existing corporate practice of medicine statutes. However, you'll see the states noted on this slide: Oregon, Massachusetts, California, and Indiana, who are seeking to refresh or strengthen or make some changes so that they are meeting the dynamics of the healthcare market today, including private equity and other agreements. And then ownership transparency, really it's been Massachusetts, but Indiana has recently introduced something. We've also included on this slide banning anti-competitive contracting provisions. That is another mechanism that states that want to have some mechanism to mitigate the chance of increased prices and other things that happen with consolidation, allowing an insurer to have more standing in their negotiations, recognizing that very large systems can really dictate and dominate the negotiations with health insurers about price, about all or not, including all physicians as that are within a health system, even when they may only need like pediatrics or cardiology, and states like Connecticut, Texas, Nevada have passed anti-competitive, have banned some anti-competitive contracting terms to allow for more fair and equitable negotiations. But that does fall short of having transaction oversight. Next slide. I think we're wrapping up. So I do just want to underscore, we recognize that this is a lot. We recognize that a state has to weigh their expertise, the collaboration that's already happening between the Attorney General's office and other agencies. And just knowing that Washington has invested so much in increasing data and oversight of the market, I do think that you may be primed to take one step further, but recognize that has to be weighed carefully given all the other considerations that the state has to make. But we are happy to answer any questions. And if we can't answer them immediately, we're happy to follow up, but please let us know any clarity, any further questions, anything we didn't touch on that we should.
Thank you, Maureen and Hayden. This has been so informative, and the depth and breadth is it's a lot to take in, but we got it.
It's a lot.
That's okay. That's what we're all here for. Board members, the staff wanted to bring forward this Model Act since it addresses that array of challenges that we've been discussing all year. So, they have kind of teed up for us some recommendations. And I'm just wondering, do you guys have questions for Maureen and Hayden and Janine and Gary as we discuss this? Maybe they can help us kind of go further. Or I can kind of present to you what the staff are thinking. Questions first or comments? Eileen, it looks like you're ready to jump right in.
I'm thinking, trying to figure out how much of this we've actually had some discussions in the legislature over, and have several years, and making sure that we put our emphasis maybe on the things they've talked about to give them a little help, nudge to get going.
Okay. So I guess what I'll do is just say, Eileen, to kind of help move this forward. If you look at tab 7, staff has some recommendations. The first recommendation is, given the evidence that market consolidation increases prices, raises consumer costs, and jeopardizes access, the board proposes the legislature use the NASHP Model Act for state oversight of proposed healthcare mergers, or to draft legislation to increase Washington State's oversight of mergers and acquisitions. So that's recommendation number 1, to help kind of frame our conversations. And I know we've been over the years doing kind of pieces and components, but we haven't kind of necessarily been able to move things or solidify everything in one neat package. The second recommendation, so I recall that at the September meeting, some board members requested that we edit the proposed facility fee recommendations with reporting requirements about ownership structures. And given the board's extensive work on that topic, staff would recommend that this be a standalone recommendation as follows. And that's recommendation 2 that you see on the screen there. And I'll just read it. The legislature should require all carriers, health systems, hospitals, and other healthcare facilities, such as ambulatory surgery and dialysis centers, to report ownership structures and legal affiliations. Reporting should include any acquisition or ownership stake by a private equity firm and be designed to provide transparency into any private equity or corporate affiliations with the system, facility, or provider. So we certainly have lots to chew on here, and we can also remind you, we can direct our data advisory committee to kind of help us as we try to push something forward with recommendations.
I have a question.
You can go for it.
Well, I'm just maybe going to ask the audience if, including that both Providence and the Medical Association mentioned that, I think including NPI and TIN, right? So I just don't know whether that's included in this recommendation or whether we need to specifically try and, in response to our, the input, public input that we have received.
Kaylee, you want to respond?
Yeah, the NPI and TIN reference that you have there, Eileen, we do have that specifically called out in the facility fee recommendations. And I think the public commenters earlier today were referring to that with some data exercises that we're doing. So not sure that we need to specifically add that to our recommendation language here, but we could certainly direct the data advisory committee to make sure that level of reporting is clear and in line with giving the best information to all parties in the system.
Yeah. Sue.
Yeah. Go ahead, Jane.
So I think it's Kaylee. I think it's a matter of the Nashville Model Act. It's almost, in terms of the data advisory committee, it's what's currently, I'm assuming what's currently reported with respect to ownership, and that would include the annual financial reports that carriers that are licensed in Washington State submit to the Office of the Insurance Commissioner. It's called Schedule Y. So looking at that, looking at what's currently required from hospitals in state law, sort of doing a comparison with the Nashville Model Act and seeing where the gaps are. Is that the kind of exercise you were thinking about?
That's right. Yep. And I'll note that the Department of Health right now is actually doing some work to try to think about how to streamline some of their reporting too. So I think there's just really good alignment opportunity with DOH, with the OIC's reports, and using this Model Act to understand what are all the elements that we want to see, how do we streamline that across these different reporting requirements, and to then make those reports useful and visible to the entities that need it.
Yeah, so Kaylee, I hear you suggesting, and Jane, you concurring that we got to get the data advisory committee to do some of that crosswalk to make sure that to advise us, but that we absolutely should be interested in moving this forward, and we should get some help from our data advisory group. Yep. So, is there discussion about that? Is there anybody on the board that feels like they need more information or don't agree with that going forward? If not, I'd love a motion.
So moved. How do you want it, for both separate or together?
Should we do reporting first? So, okay, I would move.
Wait a minute, I'm sorry, we have, oh, Kim is. Thank you, Kim. Jane, hang on one second.
Will do.
Go ahead, Kim. I think we missed you in the, does anybody want to discuss this further? Can you push a little arrow so we can see her? Kim, can you come off mute because we're not hearing you? And we are not, if you are hearing us, we are not hearing you. Maybe go out, come back in. Jane, do you want to carry on till we capture Kim?
Yeah, well, maybe Kim can also put her comment in the chat.
Oh, that's a good idea.
Just to make sure we capture.
Kim, I'm going to say that a little louder, but Jane's just saying, type in the chat if you hear us, we don't hear you. And thank you to members of the public for having a little bit of a communications telecom issue. Still not getting anything.
Is she still on?
And so maybe she did be right back.
She looks like she's duplicated on our end. She has two Kim Wallaces now on our side.
Probably trying to go out and come back in. So Jane, why don't you carry on until we get Kim back in? Then I'll interrupt you.
So I would move that the board adopt recommendation 2, including the direction to the Data Advisory Committee. Although it would be nice to have a time frame for when the Data Advisory Committee would come back to the board with this information.
Thank you for that. I'm thinking that we would like to put this in our report. So it would have to be fairly rapid response.
The data committee is not going to have time to respond.
Right. Oh no, I'm saying it's fine to have it in the report as it is. But, and the question is when in 2025, right? That's,
Yeah.
Yeah.
Okay, so those that are in the room, we got to start talking louder to the ceiling because Bianca's saying we're kind of muffled. So thank you for that, Bianca. We will do that. We will use outside voices. So Bianca, we're trying to figure out the timing of Jane's motion. So there was just a question about, I think Jane was sorting through like, how do we put some time frames? And Michelle was saying that this will be work in 2025. And I think we're pondering, can this be done kind of during ledge session or is it after? Michelle is saying, no, it cannot be done during ledge session. Louder, please.
Right. So I guess the question becomes if the board is putting this in as a recommendation and it's something that a legislator decides to take up during the 2025 session, are we saying, no, nothing can happen until the advisory committee comes back? Or are we saying if there's legislation, one could integrate into the legislation a role for the data advisory committee to come back to the board with the explicit elements of what a reporting structure would look like that acknowledges what's already reported to state government. Is that better?
That's better. Thank you, Jane.
Yeah, because we don't want to miss the next legislative
Right.
session with these.
Right.
Yeah.
So we want the report to reflect kind of this ability for legislative action, but we want the data committee to certainly keep moving as the legislature gives them direction to develop this.
Right. I think we want to acknowledge in the recommendation that should the legislature take this issue up, that the data advisory committee could have a role in informing the elements that would ultimately be reported.
Great, thank you for that clarification, and we've got it recorded, so. All right, so Jane has clarified recommendation number 2. Yeah. And staff are saying that they would write this recommendation so that the should the legislature want to get more directive and specific with a CRISPR timeline, that we would incorporate that into the report. Right. Is there a second?
I have a question.
This is Greg. I second.
Thank you, Greg. Eileen, you had a question.
Well, I just want to make sure that we're including in this that the first recommendation, or that the recommendation that's at the top of this page is going to go forward, and what Jane said is the clarifying about the data.
That's correct.
Okay, just checking.
Appreciate that. All right, so we have a motion and we have a second from Greg. All those in favor say aye.
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 Any opposed? All right, we have approved that motion, and thank you, staff, for bringing that forward.
So then what about recommendation?
How about, yeah, I was going to ask about recommendation
Fine.
1.
I would move we adopt recommendation 1.
So Eileen is moving that, given the evidence that the market consolidation increases prices, raises consumer costs, and jeopardizes access, the board proposes the legislature use the NASHP Model Act for state oversight of proposed healthcare mergers to draft legislation to increase Washington State's oversight of mergers and acquisitions. That is Eileen's motion. She would
I
like
second it.
and Greg is seconding that. Is there a discussion on this? I'm not seeing any, although I'm seeing Ingrid's head shake, yes.
I mean, no, it's very general, and I think that's okay.
Right, and I
It's-
think
yeah.
for purposes of the report, it's clearly we're building on the reporting, the current transaction reporting that's in current law, right? And and I'm on slide 53, where Maureen sort of said, here are the key elements of the model, right? It expands the scope of entities covered, transactions covered, enforcement authority. So in essence, it's like building on the base that Washington has and then adding the elements the critical elements from the NASHP model. That's how I'm understanding this. Is that a correct
Just
understanding?
my understanding is that we're kind of laying out that framework, crosswalking, and then making the recommendation that the legislature adopt components that we haven't
Yes.
fully
Okay.
implemented. And I just want to pause for a second. Kim, I think I'm getting a text from you that you can hear, and I believe we can hear you. Do you want to jump in and add any comments on this rich conversation? Uh-oh, and if you're speaking, we're not hearing you. Is struggling. She tried to accept the promotion. She says she's getting.
She's in the room. There's two.
I think you're double muted. She's trying to participate fully, but okay. I think we'll wait till she texts me or jumps in. So Kim, please feel free, if you do try again, just jump right in because we're not hearing you. All right.
Should call your phone and tell you.
Put her on speaker.
Good point. Sim, you can call my phone and we'll put you on speaker or we'll interpret for you. But Ingrid, did you want to jump in?
Sure, no, this is just a friendly addition. It just the in order of operations, these fit well together. And I would think the number 2 the first course of action is to have more data, see what's happening. And the second course of action would be then more oversight. So it feels a little, I would suggest reversing the order.
Thank you for that input. All right, we adopted the second recommendation. We still have the first recommendation because we've got some technical issues trying to make sure we're capturing further discussion. We're not getting anywhere with Kim and she's not calling my phone. So I'd like to go ahead and just call for the vote. Let's see. So we've got Jane's first, Greg's second. Oh no, I'm sorry.
No, it's mine.
I'm sorry.
No.
Eileen's first, Greg's second. So all in favor towards adopting the first recommendation, please say aye.
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 Are there any opposed? All right, Kaylee and Michelle, I think we've given staff direction and I want to thank our consultants for laying this all out and board for taking action. And we will certainly be calling on our committee, data committee, to be rounding things out.
And I think there was interest in circling back to the discussion we skipped. The best practice.
Okay, so sorry. Do we want to just go back a little bit and talk about other states and the best practices and what we should round out in our report to the legislature? So taking us back, sorry, I'm a little ADHD, too much coffee today, Kaylee's laughing. Do we want to go back and just talk a little bit about kind of the other resources that the other states have? Given that, we now have really rounded out some future work that's going to require us to really think about what are those best practices for Which I also will just tell you, given kind of where we are hearing the budget climate and the national kind of election shift is going, it concerns me a little bit that we'll have a mismatch of work to do without the commensurate resources or structure. Because we've got a lot of good things happening at HCA with new staff. We got a lot of good things happening over at OIC with Jane and her crew, and DOH collecting information, and the AGs doing their thing. But how are we going to adapt some of the structures from the other states to make recommendations to the legislature about how we go forward? Any thoughts?
Well,
We're louder.
Thank you.
We're gonna back up, board members, we're gonna back up to page 30. I think it's under tab 30.
but the best practices report is going to the legislature, correct? And so what you're asking is if there's
Recommendations.
well, I think that if we can identify things that would help the budget or other of the ideas of other states of how they have paid for this, I think we should elevate that, I guess, or.
So Eileen, one of the very specific things is HCA does have the legislation about the PEB and SEB pricing. And so I hear you kind of saying, we might want to really call that out, that the board endorses or supports that movement, that kind of cost containment move. I think I hear you saying that.
Yes, having had some experience in this, I can tell you that they're going to be looking for ways any savings thing that we could do or anything that brings down costs that we should be definitely highlighting and encouraging, like flashing red lights towards this direction.
I had noticed that reference-based pricing, although we've had a lot of discussion and it was a key recommendation coming out of the OIC portability report, was not in the executive summary. So that's where I also had that thought for the same.
So we will make note of that, Ingrid, and make sure that staff, as we refine this report, this is exactly the kind of feedback we're looking for to, strengthen the report to the legislature. So we will make note of that and work with our consultants as we refine the report. Thank you for that feedback.
Although I do need to technically say that what's in the report is not technically recommendations to the legislature. We have a new insurance commissioner who will be making that decision about whether she wants to recommend pursuing any of the options in the report.
The issues explored in
the
actuarial.
The report provides a response, a good faith response to the question, what would happen if this policy option were adopted in Washington State, and uses Washington State data for the analysis.
I recognize we have new administrations coming in.
Yeah.
But it's going to take them a little while to get their feet.
Yeah, I'm just clarifying Ingrid's statement.
Carrie, I think you're trying to jump in. Do you want to help frame this a little bit more? Or have any questions or thoughts about how we should be assimilating more of this best practice information in our thinking or our report? And if Gary, if you're speaking, we can't hear you.
No, thank you. I guess I was just interested in whether among these different topics, there are any which strike the board as worthy of further examination. So I'm hearing that reference-based pricing could be one, and it seems pertinent because of the proposed legislation. So we could certainly devote a future meeting to a more in-depth discussion of that policy option, how it would work, pros, cons, for the board's consideration in determining whether is interested in making any kind of recommendation or not with respect to that particular policy approach. So really just looking for guidance from you all as to what would be helpful going forward.
So I hear Eileen kind of endorsing that we should really uplight that we think that that's the kind of push forward to include in the report. Bianca, that's one thing, Gary. Bianca, did you want to comment?
Well, I think maybe I'm just looking for some clarification, I guess, about how these best practices pieces are going forward, because we just voted on recommendations that seem to address market oversight authority, but we don't really have any recommendations around the other things. It's just, is this going into a report that just says this is what happens in other states? And that's it? I mean, is that typical? I guess I'm trying to understand, like, are we trying to make a statement? I mean, I understand that maybe we can't say we need more money to do better data collection, but should we be spending this time to think about other recommendations that we want to attach to this? Is that part of what we're discussing here? I'm having a little hard time catching on to the discussion happening in the room, so sorry if I'm just missing something.
Yeah, well, Bianca, here we have kind of trying to braid these two things together, because we need kind of the best practices of our structure and the investments to implement some of the things we're saying really should continue to happen. Although we are, as I said earlier, we know we're going into some pretty significant budgetary constraints and some very interesting unknown national challenges likely coming at us, although the previous Trump administration actually drove a lot of transparency opportunities. So I think we're trying to just assimilate in some of Gary's and Janine's presentation about, is there other stuff? Like I personally think it's unrealistic that Washington is going to adopt a 80-person health policy commission.
Right.
Okay, it's not going to happen because there's not going to be budget, and it would be great, but I don't think that's going to happen. But I do think that modernizing our APCD laws to bring those into kind of better use and functionality, or adopting some of Oregon's structure, how they have framed this in and given them some equal authority with their AG and responsibility. We don't have those staff to enforce kind of that oversight program right now. So if we are going to opine about, well, we like Oregon's or we like Rhode Island's, I think in the report we have to give some direction to our legislature. We got to report out to them. We've studied this stuff and we need some of these components, but we got to figure out some of the resources we need as well.
Like, for example, like I'm hearing that I heard it now said twice that there's data activity happening across multiple agencies. So is it appropriate to say something like we recommend that there be a point person or some group that is coordinating these efforts? And maybe that's already happening, but maybe we need to make it more explicit.
Yeah, thank you for that. And Gary's trying to jump in. Gary, did you want to respond?
So you raised the right question, Bianca. So let me just explain how we went at this. You all and the legislature have to decide on what the policy is. And then once you've decided on what the policy is, then you can look to other states for how they have implemented that policy in ways that might be something you'd want to look at and emulate. So we didn't feel able in this report to say this is the policy that Washington to pursue. We didn't see that as the role of this report. What we saw the role of this report is like, if you want to have more comprehensive data and you wanted to be able to look at it holistically, take a look at what Massachusetts has done in creating one place where all the data goes and one place where the data analysis and reporting happens. That's it, as an example. So in looking at each of these, authority to enforce compliance is a pretty obvious one, right? I mean, you either want to give this board some authority to actually enforce the cost-based benchmarks, or you don't. And if you do, here are some of the ways that states have done that. And they're fleshed out in more detail in the actual report itself than obviously just in these bullets. So it really depends on how much of a concern, how much of a concern do you have with consolidation in the state of Washington? Well, if it's a big concern, then here's what some states have done to address that concern. So it's kind of these best practices have to follow a decision as to what you're trying to achieve with this board and with state policy more broadly, I would say. Does that make sense?
Yeah, that helps a lot. And I think, I think as part of it, I'm also hearing is that maybe putting forth some recommendations, though, without knowing that there's going to be funding to do some of these things might not feel quite right. Am I also catching that piece of it? Or it's, what's the point of a recommendation if it's not funded to do so? So if we say, yeah, we would love to have all the data in one place, but there's nobody paying for the staff to do that, that doesn't seem like a meaningful recommendation right now.
Yeah, I mean, I think that's a really decision for you all to make in terms of how aspirational you want your recommendations to be and how practical you want your recommendations to be, right? And there's arguments for both. I mean, you can be very aspirational, recognizing that maybe this year isn't the time, but you're putting out something, for consideration that maybe could be taken up at a later time. Or do you want to really be looking at what's achievable in the nearer term?
Thank you.
So I really think kind of hinting, certainly on the reference-based pricing is really important just because we need downward pressure on cost containment. I mean, our clients and consumers are begging us to do something more swiftly to help. And we need to boldly say to the legislature, we're hearing this, it's happening. And so to me, that market oversight authority is really important. And I think that ongoing kind of cost containment move with, for one instance, the reference-based pricing are things we should really apply. I think that, again, I'm a little biased to Oregon just because I see them being kind of practical with few staff and really harmonizing things to make kind of things come together a little bit more. I just don't think it's realistic that we're going to have a Massachusetts. I mean, California, there's like 6 of our Washingtons. So we're never, that's just out of our realm. I don't think it's realistic for this to really come out of the whole insurance commissioners space, the Rhode Island model. They're a tiny little state. And Jane, maybe you disagree or you've got some thoughts about what more. But I do think the harmonization with the Attorney General's office is really important because I think sometimes they are doing some things that we aren't necessarily doing in a synchronistic way. And I think Janine is trying to jump in. Go ahead, Janine.
Oh, I just wanted to add that having been working at the Oregon Health Authority when we consolidated into an Office of Health Policy and Analytics, is we really pulled from different areas in collectively. So we didn't necessarily have to add a ton of staff. We just kept kind of merging things so that the data was all coming into one area. The actuaries that were working with Medicaid came over into that same area. We positioned the policy staff really close to that area so they could have a lot of back and forth. And then talking to Sarah Bartleman, who you've heard from also, as they added these 2 new programs since I left the health authority, they just kind of built on top. So they didn't have, that's why they get by with such few staff really focused on these endeavors, is that they've really just built a more coordinated, cohesive way to look at, to get and have those analysts and data scientists talking to each other. And it's also what we heard in interviews with the big behemoths like Massachusetts and California, are that it's also that cross pollination of thought and efficiency by being kind of all more collegial together rather than having to be in totally separate agencies that never or rarely interact. So I don't necessarily mean that you need a lot of money per se. It's really just thinking thoughtfully about how to strategize to bring as many folks to be working more collaboratively.
Yeah, so Janine, I see it again in the report that, as you all have the draft, is we will again point out these other states and then point out that the board has had conversations and that we think that it would be wise to make some legislative maneuvers about harmonizing kind of how we work together, and that we consider kind of future next steps, like an office or how, maybe this board gets some more, I don't want more committees because I feel like we have done I feel like we've done so much to get the outside input and kind of harmonizing that, but now we need to start really getting the state agencies to aggregate that data. So that's how I see this coming together with kind of the best practices section.
So one way to think about that is we've just adopted 2 recommendations, both of which, in order to actualize, we're going to be pulling from, right? What's DOH's role? What's OIC's role? Like, let's think about reporting. What information is DOH getting? What information is OIC getting? There might be information about private equity firms somewhere else in state government that we don't know about. So one could, and then on the M&A activity, by definition, right? If the recommendation in the NASHP Model Act is not to have the AG be the exclusive entity that's doing M&A oversight, because there are a broader set of considerations, there we're already saying, okay, we're talking potentially about pulling from multiple entities and pulling in together. So I think the report could build in that adopting these recommendations and any others would merit our looking across state government at where we have expertise and where we have data, and we can use it more effectively to inform policy. And that, because that sounds like kind of, Gary, one of the best practices that you're talking about, right? Or Janine, the same, right? Is that, am I hearing you?
Yes, that's right.
Okay. I mean, another thing to think about for the report is there's a lot of discussion about consolidation and the impacts of consolidation. There are policies that are responding to the fact that consolidation is already here. There are policies that relate to trying to influence the degree to which further consolidation happens or how it happens. And so thinking about which recommendation relates to which side of that calculus, I think is helpful too.
That is a great area to
Yeah.
look at where we have most. David, I think you wanted to jump in.
Thank you. So just on this, on the goal and what we're hearing is a best practice of harmonizing staff across different state agencies and other types of entities like public-private partnerships. In the current budget environment, we would struggle as a state to create a new big and deeply funded office of health policy or health policy data and analytics. But it can be a best practice recommendation to drive that level of enhanced coordination that should, that could happen. I don't know that it requires legislative direction. It could also, if it's called out as a best practice with the intent to drive deeper coordination, that would be helpful in itself. In an environment that could lead to something later down the road that is a consolidated office that's more robust and more that has the value of more funding. But I think at this point it could be worded in just a light way of like, and we need coordination across state agencies and other entities.
In the spirit of getting us to our delayed break, I'm hearing good, robust conversation that we want staff and our contractors to develop this best practice component of saying, yeah, we got to take a next step when our data committees and when we identify where we have some weaknesses, because we want to drive this convergence effort between our agencies, hopefully someday into more of a kind of an Oregon structure or maybe an office. But I think staff, you've got enough direction to push this forward, and we will be looking forward to seeing it in the draft report as it continues to evolve. All right. So with that, I think what we're going to do is thank you to all of you, Gary, Janine, Hayden, Maureen, because those were great to tie those two together. We're going to take a quick 5-minute break, just 5 minutes to stand, go get water, and then we'll be right back. So members of the public, just sit tight, and we're just going to take a stretch break. All right. 5 minutes. Bye over here. Yes. Kim's back. Kim, welcome back.
This one, Bowden. It's just like wearing a tent. It's very comfortable.
Matt. Currently on that short break.
What you say? I'm gonna be. Yeah, you have to be.
Lazy. All right. Kim, I think, can you do a sound check? Kim, can you just say
Yeah.
hi?
Yes, hello, everyone.
Okay, we got you now. All right. Board members, thank you for letting us do a quick break, stand break, help break. I want to get us into our next topic. This is going to be Joe Dielman from IHME. It's going to present and lead the discussion on the DEX report, which we last heard during the May meeting. This updated report has incorporated feedback from the board and the advisory committees, as well as extended the reporting years out to include 2019 through 2022. Presentation materials are behind tab 8, and the narrative DEX report can be found in Appendix B of the legislative report, tab 10. And I want to note that this report from IHME is not a preview of the performance against the benchmark. HCA is working with the carriers and providers on the benchmark's performance analysis now, and that's going to be the topic of our December 12th public hearing. I know you all can't wait till we get that, and it will be coming. It's in a refinement period. And welcome, Joe. It's great to have you back. And we missed you at the UW meeting this morning up in Seattle. But anyways.
Sorry, I wasn't there. I'm home today. Well, hopefully good things. So good. Well, I'll dive in. Thanks, everybody. It's nice to be back and be able to present this material. Like Sue said, this is in many ways it's an update to the material that I presented last time I was here. Since then, we've worked hard to take our estimates that extended through 2019 and update them through 2022. And so today really is just me presenting those updated estimates. There's no board action that needs to take place, but it's more for context setting and awareness for you guys. So next slide. So this is the slide I've showed you before. I won't belabor it, but it's just to remind you what the ASI is. Our goal is to provide you with kind of specific analyses on cost growth trends in the state of Washington. It's a 2-year project. We're about 1.5 years into the project, and we're really excited to be finalizing our kind of first main report, and that's what I'll be showing today. So next slide. So just a quick kind of historical context of where the ASI is. About a year ago, a little bit less than a year ago, you guys endorsed our analytical strategy. And the analytic strategy had 3 key components. The first was to estimate spending and utilization per capita and per prevalent case. The second was direct age and indirect risk adjustment to those estimates for comparisons. And then the third piece was to decompose those differences in spending across time and across location. And we've done most of that so far. We're still going. Our 2-year contract or 2-year project is not done yet. But at this point, we've really done the first and the third of those main pieces. There's probably still a little bit work to be done, but by and large, we're complete. If you want to hit the next slide. So then in April, or in May, but in April, I think we shared initially our preliminary disease expenditure report that was based on previous research that we did. It wasn't necessarily tailored to those 3 things, but it was touching on them. And next slide. And then today, what we're doing is providing the updated report. And like I mentioned, the main point of the update is probably 2 things. The first is we've updated the estimates through 2022. So they're quite a bit more recent, still a 2-year lag, but getting a lot closer to the present. And the report is professionally laid out. If you take the time to look at it, it pops out a lot more. The key messages jump out. The figures are more pleasing, and hopefully because of that, it can be easier to use and more useful to you. So I'll share now, as we kind of go through the slides, essentially the main figures from the report and talk through them. Because this is in some ways review material, I'll move pretty quick. But as always, you should just interrupt with questions or concerns or something that doesn't make sense. And I'd be happy to pause or slow down if that's what's useful. Next slide. Oh, I was forgetting this one, but I guess the main point of today's meeting, just to remind you, is to review the updated report. And then lastly, as we have about 6 months left of this project, there's not a lot of time for more analysis, but there, certainly is more things that we hope to do. And so if there are specific things the cost board is interested in seeing, always interested in taking direction, and happy to consider what we can squeeze in to the work that we're already doing. So please, again, interject with that, as well as questions as we move forward. So next slide. So this is, for me as a data person, this is the slide I'm most proud of and excited about. Since we last talked, we incorporated the Washington All-Payer Claims Database into our analysis. So that was a big move. It's what allowed us to extend from, our last year being 2019 to be 2022. The Washington APCD, of course, isn't perfect, but it provides a huge amount of information. And we've been able to synthesize and harmonize that with the analysis that we've been doing for a while, but really use it and leverage it to take us through, to make more years of estimation and to feel more concrete and feel better about the estimates that we are making. Essentially, we've been able to reduce some of our uncertainty in the modeling that we do. Next slide. So this is kind of a snapshot of where Washington State is relative to the other 49 states. And on the x-axis here is spending in per capita terms. And you see on the vertical axis, on the x-axis is the growth, excuse me. The y-axis is the spending per capita. And so on that vertical axis, Washington is towards the bottom. In fact, it's the sixth from the bottom. So this is something to be proud of and excited about. It doesn't mean that there's not excessive spending on healthcare in the state, but it does mean that we're below the median. If we're looking at growth rates, that's the x-axis. And we're looking at growth here from 2010 to 2022. We're a little bit above the median growth rate. And so growing a little bit faster than the median state at, just below or just above 4.5% per year from 2010 to 22. Next slide. So this is kind of a new look for us to be able to look across the payers, which we have as the columns, and the types of care, which we have as the rows. And so you can see in the bottom right corner, the total amount of spending that we were able to capture for 2022 was $60.1 billion. And that's our estimate, the ASI's estimate of total healthcare spending in the state of Washington. And it's really important, those asterisks that you see on the side, that this is not the official estimate for Washington State. This is, what our kind of analytical strategic group in ASI group is able to estimate based again on the APCD. But it's important to recognize it is an estimate. It's not an accounting exercise. We're approximating how much we think took place in spending in 2022.
Joe,
if you're looking across those columns, you see that almost 50% of the $60.1 billion is from private insurance. So you see that that's $26.4 billion in 2022, followed by Medicare at $16 billion and Medicaid at $10.4 billion. If you look at the rows, about 50% of the spending is from ambulatory care. And so for us, ambulatory care consists is a pretty large bucket, obviously. It includes things like urgent care, primary care, ambulatory surgical centers, even pharmaceuticals that are administered at a clinic with a physician would all kind of fall into that ambulatory care, that outpatient care bucket, which again is about 50% of the spending that we're tracking. If you look at the cells in the middle, the ones that are colored, you can see not only the total amount of spending, so the biggest buckets here, of course, are the ambulatory care for private insurance with $15 billion in that bottom right corner. But the other thing you see is the growth rates. And so the bright oranges are the ones to really draw attention to, and especially the bright oranges with big numbers in them. Those will be categories where we not only have a lot of spending, but the spending over the last decade from 2010 to 2022 is growing essentially at 6% or more. And that's a per annual growth rate. So that's really kind of remarkable growth. And you see categories like Medicare spending on pharmaceuticals jump out there, Medicare spending on ambulatory care, and similar, some of the private insurance spending is growing a great deal as well.
Joe,
And then some, yeah, go ahead.
but finish that statement, then Jane and I both have some questions.
Awesome, that's great. I was just going to say the places with the dark blue or gray is where there's less growth and less spending. Go ahead.
Okay, go ahead.
Joe, would hospital outpatient department be an ambulatory?
It is, yeah. That ambulatory bucket is really kind of a hodgepodge of a lot of healthcare. It is hospital outpatients, it's primary care, it's urgent care, it's physician administered drugs. It's a lot of things. So yes, it is included in that bucket.
Thank you.
Bianca, go ahead.
Hi. Yeah, thanks, Joe. Just two things I just want to clarify, because this is over a 12-year period, right? So
Yep.
is some of this spending related perhaps to an increased number of people who have insurance where before they weren't even having insurance? And then the other one is when I see home health being red or orange and there's high growth, that's not necessarily a bad thing because I believe we're trying to move people out of home skilled nursing facilities into home health. So I just want to make sure that that's these things are caveated somewhere.
Yeah. Thanks, Bianca. Absolutely. So, I mean, your second point is the one I'll kind of jump in and reiterate. Just because there's growth in a category doesn't mean that that's a problem. There's, two reasons for growth. One would be more coverage. And we know that during this time period from 2010 to 2022, for example, Medicaid was expanded and grew, number of beneficiaries increased a lot. So some of the growth that you see in Medicaid makes a whole lot of sense. And you highlighted home health. Home health isn't a lot of spending to begin with. It's only 2 billion of the 60 billion. And I think you're right. There's lots of reasons to think that home health is a very cost-effective means for providing healthcare, especially if it can keep people out of nursing facilities, which we know are more expensive.
Well, and noting that nursing facilities has been declining its growth, it seems like.
Yeah.
They went from
Yes,
red
exactly.
to dark gray to light gray over the
Yeah.
same period.
Absolutely.
So, Joe, my question to tag on to that is this is non-claims. I mean, this is just claims data, correct? This is not like the supplementals or the DSHP or long-term home and community-based. This is post-acute long-term care. This is in the very medical realm, correct?
This is going to be in the very medical realm. It's what we capture as health expenditure. It's going to be claims based, or we have a little bit of data, of course, especially on the uninsured. That's data is best for hospital and emergency department care. But a lot of things that are paid for out of pocket and are outside of hospitals aren't going to necessarily be captured in these estimates. So that's exactly right, Sue.
Thank you. That's really helpful. And I'm sure our consumer groups are very interested in that out-of-pocket growth.
Yeah. And in a moment, we'll skip to another slide. Well, let's just go one more forward and then I'll come to that one in a moment. So this is just the breakdown by age and sex and type of care and payer. You can see really that in the state of Washington, we spend the most amount of money on the 65 to 69 population. That is mostly driven by population size for that age group, as well as need and utilization. And you can see here that, of course, after the age of 65, Medicare jumps in as the biggest payer, and before 65, private insurance really is the lion's share. One thing that often surprises people is how much private insurance is spending after the age of 65. This is, people tend to think, oh, Medicare after 65 and private insurance before. And of course, that's true as far as the majority of the spending, but there is a major role that private insurance pays as supplemental insurance for the post-65 population. And then I think the figure on the right just really highlights this ambulatory care bucket and how big it is. Really throughout the life course, we see that blue bucket is the biggest. And that really is a lot of that kind of bucket that I think of as a hodgepodge of a lot of things. And to be super candid, in our long-term goals for this project, we aspire to break that out because I think from a policy angle, knowing the difference between ambulatory surgical centers and emergency or urgent cares and primary care is, really different. Those are very different things. Kim, go ahead.
Hi, policy thinker people anticipating that the share of commercial will maybe be pushed upward there in that 65 to 70, even 70, 75 as people work longer?
That's exactly right. I mean, I think there's two reasons people have, well, a couple of reasons, but two that jump out on why people have private insurance post 65. There's supplemental insurance that's purchased separately, so like a Medigap sort of program. And then there's people that are still working or have pension plans that include their actual private coverage as well. And as people work longer, they're going to, of course, have that access to private insurance for more times. Next slide. So this is starting to get at, I think, what Bianca's question was, and the growth rates that we see that are not in total amounts of spending increase, but in terms of per beneficiary. So this is a very similar slide to what we had two ago, but instead of looking at total spending, the 60.1 billion, we're looking at spending per capita or spending per beneficiary, depending on which column we're looking at. So for Medicare, Medicaid, and private insurance, it's in per beneficiary terms. And when you see something that's bright orange, that's where in per beneficiary terms, there's a major increase over time. And so we see that, of course, in per beneficiary terms, Medicare spends more than any of the other insurers, more than private, almost double more than private and Medicaid. And it's also growing the most. And that, of course, partly has to do with the aging population in the state. 75-year-olds are more expensive than 85 or than 65-year-olds. And so as we have more and more older population in Medicare, you see that spending goes up. But it's also driven by other things as well. Kim, did you have another question? No. Okay. So Medicare jumps out as the most expensive. Not a lot of surprises there. Medicaid and private insurance are about half as much. And then in per capita terms, again, we see ambulatory care and inpatient care really jump out as the most expensive. And if there's not questions, I'll go to the next slide. So this just highlights the growth over time. The disaggregation here is by payer. And so you can see the green on top is private insurance. So that's the largest piece, as I mentioned before, almost 50% of the total spending. But where you see the growth is taking place is more the Medicare and Medicaid. That's where the growth rates are even higher, above 6% per year across the 12-year period. And again, this, to Bianca's point, doesn't capture the changes in the number of people being coverage. It's just the total outlays, the total essentially budget coming from the Medicaid budget or from Medicare. But we do see it's growing quickly. Next slide. So this is the same slide, but instead of being disaggregated by payer, it's disaggregated by type of care. Again, the dark blue, which is almost 50%, is going to be ambulatory care. The next up is inpatient care, followed by pharmaceutical spending above that. And here what we see is the growth rates for each of the type of care. The one that jumps out with the most spending or the largest increase is going to be nursing facility spending and home health at the top. And then we see the ambulatory care at the bottom. Next slide. So this is a slide that I showed before. It's a little bit, probably the most complex slide that I'll show. And what it's intended to do is to try to explore why there's these increases in spending. And so on the left is ambulatory care. The next column over is inpatient care, and then pharmaceutical from that point over. What you see in the top, the percentage, is the fraction of the increase in spending that could be attributed to that type of care. So what we see is that 57% of the increase in spending is an increase in ambulatory care spending. And similarly, 19% of the increase in total spending is from inpatient care. And then what each bar does is it breaks apart the drivers of that increase. And it really focuses on 4 different categories. It says, are we spending more because there's more people? Are we spending more because there are older people? Are we spending more because we're utilizing more services? Or are we spending more because each time we utilize a service, the price is higher or the intensity of care is higher? And that's that light purple is the service price and the service intensity. And of course, we'd like to break those things apart, but at this point, we're not able to. So they're kind of an aggregate driver of increase. And I think the number one takeaway from this slide is that really across all the types of care that we're exploring, all 7 types of care that we look at, the service price and intensity is really the largest factor that we see increasing. We
Okay.
know prices are going up, and we know that the intensity of care is going up as well.
So this is a super important slide because Gerald Anderson told us probably 10 years ago, it's the price is stupid in his article. And then his second article was, it's the price is stupid again. And now Joe is hitting us with these great graphs saying, look at the prices.
Stupid.
Again. So I guess
Really?
this is another great visual depiction of we continue to get, we really need in our reports, in our report going to the legislature to say, we have beat this death, it's the prices, and we have to keep our pursuit going on cost containment of pricing. Dane.
Joe, question on intensity.
Yeah.
So can you talk to us about how you defined and assigned something to an intensity category?
Yeah, thanks for asking. And if we could, and maybe someday in this project we'd like to split those things apart. We know, like Sue was saying, prices are so important, and we know that prices are going up. But intensity is also increasing as well. And so what we mean when we say service price and intensity is we just mean the total amount of spending associated with an outpatient visit. So that's what that ambulatory care means, is that for someone to go receive services and leave an urgent care setting or an outpatient surgery or primary care checkup, this total amount of spending for that visit was higher. Now, what we don't know is that if each one of the services cost more, or if what's being substituted is just more services or more intense services. So an example would be if someone could substitute an MRI for an X-ray, we know the MRI is going to be way more expensive, it's way more intense, and that would lead to an increase in price and intensity. Doesn't necessarily mean that the MRIs are more expensive, it just means that the services that are being provided are more expensive. It might also just mean that the MRIs are more expensive as well. And so that category is just capturing, like I said, the total spending per visit. On the inpatient side, where we see 19% of the total spending is, that the spending is looking at total spending per admission. And so we see that the spending per admission has gone up dramatically. It's also worth noticing that utilization for a lot of these big buckets, like ambulatory and inpatient and pharmaceutical, is down. We see that people are spending more because they're older and there's more people, but ultimately the number of visits that we're seeing in an outpatient setting, after adjusting for the fact that there's more people, is down. And so that actually leads to a decrease in spending, but it's when people go that they're spending more, be it because of prices or more intense care. Yeah, Kim?
How should we be thinking about cost and actually cost drivers in the service price and intensity dynamic? How can we know what the factor that costs are playing?
So I don't have a great answer for that. I think it's a really important question. I think what this figure says to me about costs is we can take away the 3 bars that are on the bottom, the 2 oranges and the darkest purple, right? That tells us, there are more costs because there's more people, but that's, you know, that's not what we actually want to be thinking about. That's not the concern here. Same would go for older people or less utilization. Those are all things that, you know, in some ways are what you don't want to be focusing on. What you do want to be focusing on is that light blue or light purple, which I think is, you know, where there's a lot of uncertainty about what is cost versus, you know, in some cases, what might be overuse, what may changes in prices, that sort of thing. Yeah.
Right. I'm just thinking of a lot of the comments that we've received and, you know, the certainly during the pandemic, you know, the data and certainly stories reported, you know, about shocking changes in costs, you know, in cost structuring. So I'm not looking at this and saying to myself, oh, well, I'm sure it's just cost that nobody can, you know, I'm not saying that, but I am saying that very real cost pressure
absolutely
is of course embedded here.
Yeah, and I think you're right. I think that's totally true, Kim. I do think, you know, we were strategic in going, you know, our first analysis looked from 2010 to 2019 and kind of avoided 2020 and 2021, partly because we didn't have the data, but partly because they are such anomalies, especially 2020. And now we're looking at 2010 to 2022. It's, you know, in some ways it's ignoring 2020 and 2021, the years of you know, the biggest impact from COVID.
Yeah, no, thank you. Thank you.
Joe, I'm just going to give you a time check. You have about like 5 or 6 minutes, and then we're going to
Perfect.
for more discussion, even though we're discussing as we go through.
Yeah, no, that's great. Thanks for the time check. I think this is the most important slide. We'll go through the next few quickly. So we can go to the next slide. So this is the same slide, but it's broken out by payer now. And I'm not going to belabor each bar other than I think when you look at it at a quick glance, you see kind of the same patterns that you saw on the last slide. The colors are the same. And so that light purple is the driver, the key driver in pretty much all of the increases in spending. So in the first block of columns, you see it's Medicaid spending, and it is price and intensity that's really driving the increases in Medicaid spending. Same goes for Medicare. And Medicare is the next block of columns over. Again, you see that light purple as being kind of a main component of the increases. And then when you go all the way to the right for private insurance, you see that's the really huge driver. That in terms of private insurance, again, it's price and intensity of care that's really contributing to the most spending growth. Next slide. So this is looking at healthcare spending by disease. We've decided to break it down by aggregate health condition because I think it makes more sense to a lot of people. We see that the aggregate health condition that the state of Washington spends the most on is musculoskeletal disorders at almost $7 billion a year. Next comes the cancers at $6.3 billion a year, and then cardiovascular diseases also at $6.3 billion per year. I think the growth rates are the really interesting part of this table, and I'll just draw your attention to mental disorders, which are growing. The spending on mental disorders growing at 6.9%, and substance use disorders way towards the bottom, growing at 9.4%. So a lot of behavioral health components really growing with some of the highest rates between 2010 and 2022. Next slide.
Maternal and neonatal disorders are pretty alarming too. Just want to say.
Yeah.
Day and age where we have more ability to impact that, it seems like we continue to see worsening there. Anyways, just I'm opining.
Yeah. Thanks. And so this is that same slide. Again, I won't belabor it, except for it's looking at 4 of the health conditions that are growing the fastest and have the highest spending. So this is diabetes and kidney diseases, musculoskeletal disorders, cancers, and substance use disorders. And again, this kind of theme of what's driving the increases for these specific diseases is service price and intensity. So that's true when we look at payers specific, and it's also true when we look at health conditions specific.
Joe,
next slide.
On cancers, are we certain that we've got ambulatory broken out from the drugs related to the ambulatory? I would have thought pharmaceutical on cancers would have been much higher.
Yeah, so that's a great question. And it's certainly one of the limitations of our study. I kind of mentioned it before, but I'll draw it out more clearly. If you were to get a drug by going to your doctor's office and having them administer it, like many cancer drugs have happen, that would count as ambulatory care. So a lot of the newest drugs that are not retail drugs, meaning you don't go to the pharmacy and buy them, but they're administered at the doctor's office, would fall into that ambulatory care bucket. Does that make sense? Thanks for drawing that out. Next slide. So this is looking at the counties in Washington. It's the same setup as before, where on the y-axis, the vertical axis, is spending per capita in 2022. And on the x-axis, the horizontal axis, is the spending growth from 2010 to 2022. And you see this kind of shift that the counties that are spending the least are also growing the least amount, and the counties that are spending the most, you can see King, Lewis, Pierce, and Whatcom up in that corner, the top right corner, not only are spending the most, but they're also some of the counties that have the most growth. And I'll just remind you that what we're capturing here is not the place of service, but the actual residence of the patient. So it's the individuals living in King County that are spending the most per capita and have the spending growing the fastest. Next slide. So here's our map by payer of looking at healthcare spending per beneficiary and per capita in the case of out-of-pocket spending. And here the oranges are where there's the most spending. This lines up, of course, with the last figure on the counties that we saw that had the most total spending are also the counties that have the most Medicare, Medicaid, and private insurance spending as well. It is important to recognize there's a lot of variation here. These are not because of the, necessarily the underlying number of beneficiaries, right? Because it's in terms of spending per beneficiary. And so to look at something like Medicaid and see a span from about 4,500 to 6,800 is a pretty substantive, a 50% difference across the counties and how much Medicaid is spending on them. And you see similar variation, even more so for private insurance. Next slide. And I think this is the last one. It just highlights the type of care and where the spending is the greatest. Again, we see a lot of variation across the states. We see the counties that have the most spending, that kind of I-5 corridor especially, is high in pretty much all of the types of care. And you see really common patterns across the types of care in many ways. Next slide. That's all. Happy to take comments and questions. I know we're a little short on time, but happy to take more questions. Kim, go ahead.
Just real quick, do we have an overlay or crosswalk comparison between health status by county and spending?
I would be happy to pull that together. That wouldn't be hard at all. We could that would be something that I could share with the board. What I would do is have life expectancy by county, or adult mortality, or we could do child mortality. We could look at all three.
Yeah, we know there are factors and inputs, of course, that create health that aren't just
absolutely.
about medical spend, of course, but sort of just seeing that, there might be some interesting relationships or maybe some shocking relationships. Thank you.
Yeah, happy to put that together. Kind of excited to do so. We've looked at that at the national level, but not just for the state of Washington. Yeah, go ahead, Bianca.
Maybe related to Kim's comment is that you could look at over 65 populations. I would expect that should correlate a bit with the Medicare kind of maps that you have. And then for Medicaid, maybe identify something related to births, since Medicaid is a big payer for births, although I'm a little surprised to see the Olympic Peninsula, the north part, has such a high Medicaid spend, given that's a fairly older population there. I am curious what you do with just border people. So you said this is based on residents. So are these people who, if they're getting care across the border, what are you doing with those people?
Yeah, so generally speaking, Washingtonians that are going elsewhere we're still capturing. That is especially true in the not all payer claims database data sets, like our broad Medicare data sets or our broad Medicaid data sets are going to capture everybody regardless of location. And therefore we trace the money regardless of where the spending took place back to where they lived. That's a little bit harder in some of the other data sets, but for the earlier years, we're certainly able to capture that. And then likewise, someone coming from Portland to receive care in Vancouver or something similar to that, would be money that's attributed to their states and their counties.
Questions from board members? Ingrid?
Yeah, just a quick question. So people ask a lot, what's going on with healthcare cost inflation? Why is healthcare spending rising so fast? And then it's the price is stupid. And we also say it's a factor of price and utilization. And your data really underscores the price and intensity. But in terms of utilization, also we're being asked questions like, oh, what about new drugs on the Ozempic and new drugs on the market and people accessing more healthcare? Can you speak to utilization? Because the data shows that the utilization isn't the problem here.
Yeah, so when we factor out age and the size of the population, then utilization is not growing. And in fact, for most of the major types of care, we see that utilization is going down. So, and what do I mean when I say utilization? What I really mean is like the number of visits for a 45-year-old is less than a number of outpatient visits for a 45-year-old used to be. Now, it's not necessarily speaking again to what happens during that visit. That would be what we think of as intensity of care, but it's just the number of appointments, the number of times that they are at the outpatient clinic. Or in the case of inpatient care, the number of admissions that we have is fewer in per capita terms, again, after adjusting for age than it has been previously.
Answer me this, Joe. Can the model can we reverse it and say if we wanted to hit a 3.2 or a 2.8%, what service utilization, or I'm sorry, what prices need to be at?
Yeah, so I mean, we can think about, and I think there's been some questions from the HCA on what we could do with potential scenarios. And I think that makes a lot of sense. We can, as far as changing in population, size, and age, those are pretty easy to predict. Those, immigration is hard, but the lion's share of, the 65-year-olds were 64-year-olds last year. So we can predict that with a fair amount of accuracy. If you wanted to hold utilization constant or have a slight decline like we've seen, you could back out what you would want the changes in price and intensity to be. Yeah, that would be possible.
Yeah, and I mean, I certainly know with our reference-based pricing legislation proposal, we're kind of, again, looking at all those variables and coming in and slicing it that way. But it'd be very interesting on a total health expenditure to look at if you held. I mean, commercial is almost triple Medicaid. I mean, just to look at those proportionate impacts and then play with the model. So anyway, that's something for us to think about. Jane, did you have a question? We've perplexed Jane. She just loves it. Bianca. We'll take your last question and then we'll move on.
Yeah, just one more clarification. Where is Medicare Advantage?
Medicare Advantage is lumped in with Medicare.
Okay, it is with Medicare.
Yeah,
so
it is.
that's
And again, there's so many places we hope to improve the set of estimates. That one of those is to break Medicare Advantage out specifically.
Okay.
And the data, of course, allows that, but we haven't been able to do that yet, but hope to soon.
Because it would be really interesting to see how Medicare Advantage relates to the private health insurance market.
Yeah.
Because it is very shocking just how big that number is. And that's why I was wondering, well, is it possible they were just older there? Thank you.
Yeah.
All right. In the interest of covering our very important next topic, I think we got to move along. So Kim, we're going to wrap you into the next area. But thank you so much, Joe. It's always great to hear what you're up to and to see this in a different lens. I'd like to welcome back Janine from HMA to help us wrap up the top of the facility fees. Again, this is in tab 9 of your packet. We spent a few meetings diving deep on this topic. In our last meeting, we voted to approve 2 recommendations. Today, we're going to recap the board's findings and query requests at the last meeting regarding proposed recommendations about site-neutral payment policy. We'll briefly discuss next steps for moving forward with this broader policy goal. So Janine, over to you.
Hi, back again. We wanted to give you just a brief overview, refresh on where we had previous discussions about facility fees. If you want to go on to the next slide. So the issue, as you all remember, hospitals and some clinics charge fees in addition to and not directly related to the service provided. And as consolidation has increased, so has the use of facility fees. Hospitals with provider-based clinics that bill a separate facility fee must report to the Department of Health as part of a year-end financial reporting. They collect the number of entities in their network that charge and the number of visits to those entities and overall revenue collected and the price range of the fees. But what isn't reported is you're not capturing all entities and locations that charge a facility fee in Washington State. You're not capturing which services have a facility fee, and you're not able to quantify the impact on the consumer per se. Next slide. So if you remember in September, we had discussed the recommendations that staff had proposed to you. And we focused in on kind of going from just reporting and improving reporting all the way to some discussions about prohibitions and potential caps. There was the first recommendation was approved by the board at that meeting to improve reporting requirements. And recommendation 2 was also was approved, which was requiring more information around including the national provider identifiers specific to the location to try to track this more efficiently. And we'll go over the exact language change, but that was basically, you guys approved that. Next slide. So the prohibitions and site neutral payment policy, you had asked us staff all to look into it a little further. You wanted some information about potential consumer impact. That data isn't yet available, but could be considered in the future. There was some issues raised about would these prohibitions or caps be less effective in the commercial market because costs could be shifted to other revenue streams, such as increased reimbursement rates and adding other services or fees. So does it just change where the dollars are requested? And then there was a recommendation that from staff that site neutral payment policy should be wrapped into a broader exploration of price monitoring and regulation as you approach your work into the next year in 2025 and 2026. Next slide. As far as billing and ownership transparency, we don't really fully understand the breadth of the problem because there are challenges in being able to tie fees to one entity, even when they're owned or by other affiliates or provider groups. You were interested in more transparency, but didn't want to necessarily require more reporting, hence the recommendation number 2 to just where you're already collecting information to try to tie it more closely so you could get further information out without additional administrative burden to the to your reporters of information. APCD does have capacity to track fees with unique national provider identifiers. Other states have applied this approach. And as you had the earlier discussion on market oversight and the NASHB policy, that might allow for more monitoring of some of these acquisitions onto itself if the legislature chose to proceed with that. Next slide. So the revised recommendation on number 2 is just to add in just some specifics, just to be sure that it's clear that you require hospital-owned and affiliated providers to acquire and include that unique national provider identifier specific to the location of the care on all claims, so that claims and the fees can be tracked. And also you had requested language requiring them to report ownership structures and affiliation. Per our prior vote on market oversight, we propose shifting that into its own recommendation. The minor adjustments are in red. Next slide. I don't know if we want to go back to that last slide to have any discussion about this.
So I really appreciate kind of this follow-up, because I think I was a really big proponent of facility fee, kind of fine tuning it, but I kind of am feeling like you advised us and that we need to keep thinking more broadly and pivot from facility fees, because it feels like it could just worsen a very narrow part, and that we still have to put more systemic price negotiation and downward cost containment pressure on, or we're going to see take down price or facility fees go bubble up somewhere else. So is that, Janina, am I following you correctly? Because I was a big driver of this.
Yeah, if you go back to the earlier slide that had all four, the one with the 4 boxes.
Yep.
Yeah. So there was concern about recommendation 3 and potentially 4 as well, that you would cause the bubbling up or the whack-a-mole, or however you want to describe it. The cost may show up somewhere else. And should the board focus more on such as the proposed legislation about reference pricing, trying to do other things to work on costs without necessarily restrictions on these specific fees.
And I'd love, Greg, if you're still on, I'd love to hear Greg's perspective from a commercial perspective. But we heard strong support earlier about this reference-based pricing endorsement that we're trying to do on PEB and SEB. And it seems like that this approach would really help commercial as well. Greg is not on anymore, but I'm wondering how other board members feel about this. We don't need to vote on this today, but we should kind of strengthen this in our report as we keep pushing, the evolution of these topics forward.
Will this be included in these 2 recommendations? As amended, will be in the report, right?
Correct. So I'm comfortable that we aren't doing as deep a dive on just facility fees, but that we're broadening kind of our approach to look at how we put price negotiations and overall kind of cost containment strategies in place that assure that we're not going to have this game of whack-a-mole. Thoughts? Agreement? Disagreement? Jane and Eileen are saying, and all 3 in the room are shaking their heads. Yes.
On recommendation 2. So.
Well, yeah.
Yeah, that is the key step.
Recommendation 2 is about billing and ownership transparency. Recommendation 1 was, initially we were really going to do a deeper dive into facility fee report, which we do. We already have that. Going on. But we're kind of saying, let's not keep going down just the facility fee, because we've got data coming in, but let's keep broadening our efforts around reference-based pricing or cost containment price negotiation strategies.
And transparency.
I hear that, Sue, in terms of this recommendation,
sorry.
Which doesn't have this says recommendation 2 here. I don't know, these don't align.
The last
Are
page.
you saying that you are endorsing this recommendation or pulling away from it to focus more on other things?
I believe, Janine, on your last slide where you have red NPI, so that claims and fees.
Yep, you can move to that. That was the one that we didn't think you needed to re-vote on. It was just a clarification so you could see it. And then I think the direction to consider is let's do 1 and 2 and then dive deeper into or support the bill going forward, potentially the on reference-based pricing as a more direct approach on in addition to what you've just already talked about for Nashby's model.
So what is in red, which our consultants and staff already kind of cleaned it up for us and said, this needs to be strengthened and clarified. That's it. This, what is on this slide is in the report. I'm very comfortable with this. And again, I echo, I'm also more comfortable saying, hey, legislature, we did some work on facility fees, and what we suggested to you in our initial 2 recommendations is good. I'm suggesting that we keep endorsing kind of that overall cost containment and that overall reference-based pricing, which is price negotiations. So we're putting downward, we're saying we want to be a state that continues to put downward pressure.
My only question is when we had the discussion about facility fees at the last meeting, Greg was very much in support of, it sounded like, prohibiting facility fees. So I feel like before we close the door on that, it might be better to have a discussion when more of the board members are present.
Jane, why don't we put that as a follow-up thing on December 12th? The report's got to keep maturing.
Oh, yeah.
But we can also check in with Greg.
No, but I think having the revised recommendations 1 and 2 about facility fees makes sense. I guess the question that I'm saying is, do we want to make a substantive statement about, no, let's not do more with facility fees without having a discussion where Greg and others are present? That's the only thing I'm thinking about.
Any more discussion in January?
Right, that's 20, I'm just saying for purposes of the report not include a statement that says we've decided we're not going in that direction. Only because you want to, I just feel like there were some really strong feelings on both sides on it. So I just sort of feel like it would be.
Warrants further discussion.
It warrants further discussion. Thank you.
That's great. Thank you for that clarification. So, all right.
Great.
Other comments? Thank you, Jane. I'm very comfortable with that. Okay. So Janine, thank you for these recommendations. We really agree with your detailing red edits there. And as Jane says, we want to not totally close the door on facility fees, but I do want it so noted that we continue to take that overall strategy, and we'll continue to get the data in and understand it, and more discussion to come.
Sounds good.
All right. Wow, we have had a lot of discussion today. Let's take one more item. This is tab 10. It's that little tab 10.
Yeah, right.
This is the review of our draft legislative report. I hope you have all taken a good hard look at this. And Kaylee, let's see, who are gonna come alongside me for this walkthrough, correct?
Yep, happy to do that. So board members, you do have in your packet the draft of the 2024 legislative report. Obviously, that is subject to change based on the discussion that we had today, the great feedback that you all gave us. So here's what's in the report. It's a summary of all of the activities that you took in 2024, the recommendations that we all discussed, including today's recommendations on market oversight, those 2 recommendations we just talked about regarding facility fees, as well as the primary care expenditure ratio recommendations that you considered in August and September. It also summarizes the variety of data activities that you've undertaken this year from the benchmark analysis. It will not include the performance against the benchmark report. That's going to come out in December after you've heard that at the public hearing. But we did note about the benchmark report that was done last year. It also talks about the cost driver analysis, that primary care expenditure ratio assessment, hospital spend assessment, and the great work that Joe and his team at IHME have been doing in the analytic support initiative. It also includes that best practices report that you heard a brief overview of today from Gary, Liz, and Janine. So here's what we're asking for today. We understand you haven't gotten to see the final draft of it. We are going to incorporate all of the edits and feedback that we heard today, updating any of that language, really carefully framing the board's position and how you're thinking about contextualizing this work in that landscape of healthcare cost control. We're also going to incorporate public comments that we receive that is open on our website now. And we've asked for public comments to be returned to us by Monday, the 18th of November. So with all those incorporations, we are requesting that you consider adopting the report today, trusting that your staff is going to support and make sure that we get that feedback incorporated. And I also want to note, if you have additional edits that you'd like to request to that report, you are welcome to send those in to HCA as well, as board members and members of the public, up until that 18th deadline. So our request today is to consider a motion to adopt the report.
Thank you, Kaylee. Kim, your hand is up, and then Eileen's next.
I just have a quick question about, it's due to the governor's office on December 1st. When is it due to the legislature?
It's due to the legislature in early December, but we are being very realistic that that's probably not going to happen. We know the governor wants some time to take that in and review and get back to us. So we think it'll probably be around end of December that it would get to them.
That it would actually go to the legislature.
Right.
Okay, thank you.
That's correct. Eileen?
My question is on the executive summary. I think it's a little thin. Because I would think that the recommendations that we have voted on should be in the summary.
Thank
you. And, and whatever, going back, thinking about it, knowing how much when it gets, the legislature receives it at the end of December, it's probably only going to get the executive summary read before session starts.
So Eileen, we have already received that feedback, and we will incorporate some strengthening. Board members, you can keep sending in edits, keep working with staff. We will, if those of you that say, no, I want the final, we just will not be together to adopt the final. And I feel comfortable that we are directionally reporting out on the work and that we are in agreement about many of the efforts that are going forward. So that I feel comfortable that staff will incorporate those in. So I would ask that with these planned changes to the draft legislative report, is there a motion to adopt the 2024 legislative report? And Kaylee, did you have one more recommendation for us?
We did, yes. We just pulled this together based on the conversation that we heard in the last hour and a half or so, that there is interest in this broader reflection that prices are a big challenge, that's a big theme and takeaway from the board's work this year. And to that end, that the board would consider endorsing HCA's proposed bill to increase affordability for PEB/SEB enrollees by capping prices using reference-based pricing.
Thank you for that clarification and for getting that up on the screen for us to discuss this. Ingrid, you had your hand up.
Yes, thank you so much for that. I really felt that that was missing in the executive summary. The other HPE has also submitted one other comment that I would appreciate being included in the final, which is the header on primary care and the detail in the report. It says increase primary care expenditures. And then it says by establishing a clear target for annual expenditure growth and increasing Medicaid reimbursement. Just a suggestion that the header be increased percent of spend on primary care.
Yeah.
And I do also am concerned about some confusion. There's a lot of discussion about the covered lives proposal. So in here, it's saying increase Medicaid reimbursement. That could cause some confusion. So just thinking very specifically to make clear it's a shift and that we're about downward pressure, not increasing overall healthcare spend.
Thank you. That's a really important clarification. Jane, did you have a comment?
On that, I think I'm gonna have to abstain only because weird kind of, yeah.
No problem. We understand that OIC is a separate kind of entity and there are times where we just have to abstain. Other comments, thoughts? If not, I would entertain a motion regarding the legislative report.
I move we accept.
Eileen, thank you. Eileen's made a motion to adopt the 2024 legislative report with the two last caveats from staff on the last two slides. Is there a second?
Second.
I think that was Bianca or Kim.
Ms. Kim.
Okay, thank you. You guys, your voices, and you're right next to each other up there, so you light up. All right, so we have a motion. We've got a second. All those in favor say aye.
Aye.
Any opposed? Any abstentions? And let the record note that Jane Fire will be abstaining from that.
Yeah, I don't want to abstain from the rest of the report. It's just that one recommendation. I don't feel like I have direction from.
We will reflect that
Thank
in
you.
our notes.
Thank you.
All right, it has been a long meeting. I'd like to go ahead and get ready to close this out. I want to really thank everybody for being so focused and attentive, attending our meeting today, being here in person for those of you that could be here in person. We really, really appreciate your time. This is hard work. To our consultants and members of the public that keep jogging along with us, and staff, you guys have been amazing, especially with staff changes. Engagement by everybody remains crucial. I know we didn't hear from too many of our consumers today, although we got some great written materials, and I think many of us get ongoing input from them. So I just hope we can really keep this work moving forward, respectful and engaged, and keep working our committees, because I believe we really will continue to reduce healthcare costs and enhance price transparency for Washingtonians. To the public, the recording and the summary of this meeting will be posted shortly on our website. Please mark your calendars for December 12th from 1:30 to 4 p.m., where we are going to hear about the cost growth performance against the benchmark. And we really hope you guys will come back in person and be here in person for that meeting. And Joe, you should come down from Seattle. We'd love to have hca here too as we reveal that. So we really hope people come in person. I look forward to seeing you all at that next meeting, and thank you very much again. This meeting is adjourned.
Got only know for a week because 2 days after I get back from vacation.